Good morning, good afternoon, everyone. First of all, I'd like to thank the organizers for inviting me to talk at this family conference. I hope that every one of you has been safe from Corona. The COVID-19 epidemic or pandemic is still here. So I hope that you've all been vaccinated and safe from this pandemic. My task is to talk about multidisciplinary approach for people with multiple system atrophy. And after the introduction, I will spend most of the time talking about what challenges our treating team encounters and that could, in theory, be solved by a more multidisciplinary approach. So what are the challenges for physicians and patients alike? Because we're in this together, you know. We are challenged by the fact that this is a very rare disease. We do have reference centers. We do have movement disorder specialists that have seen many patients, have, together with patients and families, developed some experience in how this disease is diagnosed and treated. But it remains a very rare disease, and this is also a challenge because many of our colleagues do not have a lot of experience. The diagnostic uncertainty, and especially in the beginning of the disease, is a problem, and I'll come back to that. Like in many neurodegenerative diseases, we do not really have a cure for multiple system atrophy. We can alleviate, we can treat in a palliative way, but we cannot cure the disease for now. Depending on the country and depending on your personal situation, there might be insurance issues, and that might involve to a great extent or might implicate to a great extent the cost that is associated with treating this disease. And also drug availability is unevenly distributed over the world. And one of our main challenges is to guarantee continuity of care. And I mean continuity of care not only in time, but also in place, the so-called transmural continuity of care. We think that the best way to handle these problems is to organize a person-centered approach. Everything should revolve around the patient and the family. And the multidisciplinary team should organize itself around this core family. We do need reference centers, people with experience to treat and to diagnose multiple system atrophy. And that means that we have to spend a lot of time in healthcare worker education. Working together with patient support groups, I think, is very important, not only to educate and to support people with multiple system atrophy, but also in order to educate and to increase the experience of the healthcare workers. And we do need continuous quality monitoring and improvement of the whole diagnostic and care process. I know you've seen this before, but let me tell you what the problem is with this relatively broad definition. It's a sporadic, progressive adult-onset disease that either involves parkinsonism or cerebellar function and a symptom suggestive of autonomic dysregulation. This is a very broad definition, especially in the immediately after onset of the disease. This might cause differential diagnostic problems. We do distinguish these two broad categories of people with multiple system atrophy, that is the MSAP, involving mostly Parkinsonism, versus MSAC, involving mostly a cerebellar syndrome with incoordination and equilibrium disturbances. The diagnosis can be possible, it can be probable, and it can be definite if we can demonstrate the alpha-syn nucleinopathy at post-mortem examination of the brain. But the challenges occur most of the time in this possible category. And there are a number of supporting and non-supporting criteria in order to help physicians diagnose the disease. There's very little data on the epidemiology of the disease. How often does it occur? How many people do we see with multiple system atrophy? And in that sense, the patient support organizations are also very important in the sense that they contribute to our understanding of how many people exist in a particular region. But as you can see from these numbers that have been studied in the recent past, the disease is rare. And in a small country like Belgium, with 11 million inhabitants, we think there are between 250 and 350 people with multiple system atrophy. The figure on the right shows again the different type of symptoms that you're likely to encounter in this disease. Without spending too much time on the diagnosis, again, I want to illustrate the challenges that even experienced physicians and other healthcare workers are confronted with when making the diagnosis. Fortunately, we have now a relatively good consensus definition of what multiple system atrophy is. But being a little bit older, I remember that in the beginning of my career, we saw all sorts of different diseases like olivopontocerebellar atrophy, Scheidegger syndrome, striatonigral degeneration, that in the end all seemed to be diseases that were in the same category of multiple system atrophy. Now we have a better definition of the disease, but there remains an important differential diagnostic challenge. And some of the most important differential diagnoses that one might consider, especially in the beginning, is Parkinson's disease, other types of atypical parkinsonisms, and cerebellar ataxia, which also occurs isolated in advanced age. The average delay until diagnosis of multiple system atrophy is about 2 years, but with a very broad range that goes from 1 to 10 years. And this leaves patients and families also with uncertainty and also the impossibility to continue on to make arrangements, not only in terms of healthcare, but also in terms of organization of the care, housing, and so on. Insurance issues, I'll come back to that immediately. The diagnostic criteria are, as I said, possible, probable, and definite. And one of the problems that we face is that there is at present no established sensitive and specific so-called intravitum biomarker during life of the person with multiple system atrophy. And furthermore, you see all sorts of disease histories. The figure on the left shows you the different types of disease histories that we see with a problem of dysautonomia in the beginning, or with Parkinson's disease and dysautonomia arriving later, the bladder disturbances, the low blood pressure, the constipation, other types of dysautonomic features. The same goes for the cerebellar type, in which you can see several years of isolated cerebellar incoordination and falls and disequilibrium, and only see the autonomic disturbances later on. As I said, and what the table shows in the middle is that the differential diagnosis is quite broad, that you have to consider a whole range of diseases. Some might be more treatable than others. And I'm not going to go into detail of all these different diseases, but I can assure you they can look very much alike. And an experienced clinician, an experienced team knows that there are supporting criteria that make the balance shift more towards the diagnosis of multiple system atrophy, while there are not so-called non-supporting criteria that make the balance shift towards another type of Parkinsonism or atypical Parkinsonism or other type of disease that resembles multiple system atrophy but is not multiple system atrophy. And to make things even more complicated, when you study a group of patients that have been diagnosed, even post-mortem neuropathological exam that demonstrates that a person has had multiple system atrophy, even then you see some, be it rare variants. Like, for example, people that have changes that are limited to particular parts of the brain, such as the striatum, with very limited of what we call the glial cytoplasmic inclusions that are the hallmark of this disease, or a benign variant with a very slow disease course, or cognitive changes. Cognitive changes are quite unusual in my experience, but some people do suffer from cognitive changes, and there might even be a sort of a cognitive deterioration variant of multiple system atrophy. And as is often the case in these diseases, there is some overlap with other types of what we call neurodegenerative diseases, like frontotemporal dementia, Pick disease. And there have been some genetic variants that are associated with multiple system atrophy occurring in families, and that also involve the occurrence of a disease that I'm sure that you all know, amyotrophic lateral sclerosis or Lou Gehrig's disease. So this is very unusual, but even in a population of people with this atypical variant of Parkinsonism or cerebellar ataxia, you tend to see exceptions. Now, coming to care, how it should be organized and how it is organized right now and how it can be improved. Well, there are a number of symptoms and signs and problems that people with multiple system atrophy are confronted with. And REM sleep behavior disorder, which means that as opposed to what is normal during dream sleep, you're normally relaxed, your muscles are relaxed. People with incipient Parkinson's disease or multiple system atrophy and some other types of related diseases tend to have movements during sleep. These movements can be goal-directed, as if you're defending yourself against somebody or shooing away somebody that tries to enter the bed or whatever. Might be associated with nightmares, but not always the case. Also, falls can be a very early phenomenon. This is more the case in a disease that is called progressive supranuclear palsy, but especially in the cerebellar variant of multiple system atrophy, disequilibrium and falls occur early in the disease course. The autonomic dysfunction can be early, can be the presenting sign, but often is later in the disease course. The same goes for speech problems and swallowing disturbances. And obviously, most of the time, residential care, the need because of the healthcare need to be admitted to a nursing home is often a late type of problem, let's say, or healthcare intervention. And there have been some studies on how this. There have been some studies on how this and when this occurs, these symptoms occur, and how the care for people with multiple system atrophy can be organized in order to cope with these problems. For example, not in all patients, between 15 and 40% of people develop respiratory problems with the phenomenon that is called stridor. Stridor is something that leads to making often a high-pitched breathing sound because of the spasm of the vocal cords, and this might render people very anxious and also create oxygen lack and what we call dyspnea, problems with breathing as such. Some of these problems do occur early, like, for example, falling. If there are severe bladder problems, the use of an urinary indwelling catheter. Speech is often changed from the beginning, but remains understandable until late in the disease. But many people suffer from becoming more and more unintelligible up to the point where you need to use some kind of aid, be it a smartphone or a tablet or a computer or other types of aids in order to make yourself understandable. Also, when swallowing problems become so severe that you would need a gastrostomy tube, a tube that enters the abdominal wall and that remains in the stomach for months or even years, is a late phenomenon. Again, the same goes for cognitive changes. This is an expression that I often hear from my patients, and that states, "Doctor, it's either the patient, him or herself, or a spouse or another caregiver that states, Doctor, I'm confronted with an important problem because our hospital insurance does recognize a number of severe diseases like Alzheimer's and Parkinson's, but my wife or my husband doesn't have any of these, and multiple system atrophy is not even listed in the insurance policy. So I'm confronted with the problem. I cannot get any of the reimbursements or the support that I was expecting to get from the insurance." And of course, this is context and country dependent, but it's something that I often see in my practice. Very often in the beginning, in that period of diagnostic uncertainty, we see also the lack of support and compensation, again related to insurance issues. So the diagnosis of multiple system atrophy, being a rare disease, is often lacking in these insurance policies. And more often than not, there's also a failure to reimburse medication. And the medication that is used for treating movement disturbances, some of the medications are not available in certain countries, and if they're available, they're sometimes not reimbursed. And this leads to increased cost for patients and families. So the healthcare team is confronted with a number of challenges. I'm sure that many general practitioners will never see a person with multiple system atrophy in their career. Like they haven't seen any of the other rare diseases, people with rare diseases. And when they're confronted with, I'm sure they learn very fast, but they're lacking experience. And so what happens then is that very often it's the person with multiple system atrophy and the caregiver that relate to the movement disorder specialist as their general practitioner. And I think this also endangers the continuity of care. You need to have a good collaboration between the general practitioner that is very flexible, that can often, at least in Belgium, visit people at their homes. The team that works what we call transmurally in the home or in the nursing home, and they should relate very frequently to the movement disorder specialist and his or her team in order to create this continuity of care. many neurologists working in smaller clinics or in what we call peripheral hospitals, as opposed to the university hospitals. Belgium has many hospitals. We have more than 200 distributed all over our very limited territory. But many neurologists working in small clinics or peripheral hospitals have seen one or two patients, but haven't had the opportunity to develop a lot of experience. The same goes for the paramedics, the physiotherapists, the speech therapists, even the occupational therapists. They know Parkinson's disease. They know what is a person with ataxia due to peripheral neuropathy, for example, but they are lacking experience in treating people with multiple system atrophy. Some of the problems might be generic problems, and let's say generic in the sense that people with suffering from other types of diseases, neurological diseases, are confronted with the same type of generic problem, like, for example, stability, use of a walking aid. But there might also be problems that are more specific to people with multiple system atrophy. And again, there's the patient support organization that, excuse me, that might intervene and that might increase education of patients, caregivers, but also the physiotherapist, for example, in order to guide and support the care. Pneumologists are sometimes called to help when a person has respiratory problems, and especially when there's stridor or when there's some kind of non-invasive ventilatory support needed. And the same goes for the psychologist. I think a psychologist, at least in Belgium, is often not part of the daily, let's say, the team that ensures the daily care for the people with multiple system atrophy. But support and psychological support for the patient and the caregivers is very important. So unless these people are working in a reference center that has seen a number of patients, they will have little experience in something that is often neglected. People receive a diagnosis and then they leave the office of the neurologist and they are left to themselves in order to find the information they need to cope with the diagnosis and to organize the care. So there should be, and there are a number of texts that can help in order to know what is coming to you, what is multiple system atrophy, how the care can be organized, what is good care. So patient education, not only patient education, but obviously also education for the caregiver that might occur simultaneously with educating the patient, but might also, and for some reasons, be independent from educating the patient. Organizing the transmural care by regular contacts with the general practitioner, with nurses or other types of healthcare workers visiting the person at home should be one of the quality characteristics of a reference center for multiple system atrophy. And not only that, but also participation in scientific research. The only way we're going to go ahead or get further in treating this disease, even curing this disease, is by everybody, patients and healthcare workers, participating in scientific research. And anything that can improve the quality, sharing experience through an annual activity report, and participating in quality promotion initiatives. What is this movement disorder specialist, and how do you recognize a specialist? That's something that is often asked by patients that I follow. I even offer them to organize a second opinion if there's diagnostic uncertainty. And then I try to educate them in how to recognize a movement disorder specialist. It's often somebody that has had additional training, that has done a fellowship, for example, in movement disorders. Often these are people that at the same time educate their peers. They do research, they publish on the disease, on multiple system atrophy or related diseases. And these people are specifically trained and they have experience in how to take care of the many symptoms that people with multiple system atrophy are confronted with. And they are mainly, but they are certainly not restricted to academic centers. It depends a little bit on country to country, but in Belgium, people are free to choose their own doctors, including neurologists. So people with multiple system atrophy go to their regional hospital, and also in regional hospitals you will find neurologists that are specialized in movement disorders and have some experience. So it's important that people with multiple system atrophy and their caregivers are educated in how to recognize a person that has specialized in movement disorders. I've already talked a little bit on the specialist Parkinson's nurse, and because of their particular view of people with multiple system atrophy and other movement disorders, and because of their proximity to the patient, and not that the neurologist is so far distant from the patient, but because of their specific view of the care need, they are more competent in some sense in order to identify what type of healthcare need is needed for people with multiple system atrophy. And many of these experienced nurses have already had experience and they are trained in communicating on how to organize this care. And they should be part of that network of multidisciplinary teams that care for people with multiple system atrophy. What is maybe not evident, maybe not for a younger person, but certainly for a nurse that knows healthcare and the organization of healthcare inside out, I would say, is to coordinate the care provided by these different people, healthcare workers, and how to coordinate this in close collaboration with the person with multiple system atrophy and their caregivers. Often they have obtained more training in motivational interviewing. They can not only organize the care, but they can also engage people with multiple system atrophy and also give them the sense of autonomy, of control of the healthcare. They are sure in service of the person with multiple system atrophy. In the past few years we've all been educated in telemedicine, but especially when distance is a problem, I'm sure that telemedicine is going to help now and in the future. And all these people, be them the movement disorder specialist, all the nurse, the different paramedics, should work together in order to support the person with multiple system atrophy. Multidisciplinary programs are they're more likely to be present in certain contexts, and I'm talking from Belgium and with the experience that we have, and especially in the oncological setting, this is quite evident, organizing in multidisciplinary teams. As far as oncology is concerned, we sit together every week with our colleagues from different disciplines and also from oncology and neuro-oncology. We have a neuro-oncology multidisciplinary conference this is not what you mean with a multidisciplinary consultation. A multidisciplinary consultation is a consultation, if it should be called multidisciplinary, is a consultation where the care from different specialties, be them medical or paramedical, is available for the patient, and not just a multidisciplinary conference. They have their own role to play. They have their own advantages and disadvantages. I would say most of the time or always, the patient and caregiver are lacking from that multidisciplinary conference, because physicians often feel that they're not free to talk about prognosis, for example, or let's say going from curative settings to more palliative settings, again within the oncological context. A multidisciplinary program should also develop a care plan, and not in the least, I would say, is a budget important in developing such a care plan, because very often there are meetings involved, organization, and many of these activities are not what is called in Anglo-Saxon terms billable. They're not billable, which means that physicians and other healthcare workers do not receive any revenue, and not only the physician, the hospital by itself does not obtain any revenue from organizing these activities, and this might be a problem for multidisciplinary consultations. Everything that deals with organization and quality is most of the time not billable. So there should be a good balance, and a budget is something that you need as an organization. This multidisciplinary team should have weekly or maybe bi-weekly conferences with adequate representation of all the stakeholders involved. And it should be decided on whether there should be some form of representation of a patient support organization, of patients themselves. And at least patient and family should receive feedback on if an individual problem, a care plan has been discussed. In the geriatric setting, at least in Belgium, day clinics are often used in order to organize multidisciplinary care. Day clinics are clinics where a person comes in the morning, there's an appointment made long beforehand, the person comes in and then sees a number of these people within the multidisciplinary team, depending on the care need at that moment. And there are people that are sufficiently experienced in order to recognize some of the care needs. These day clinics are also at the border line between being hospitalized and being in ambulatory care. Because it's the person that comes in and the team that organizes around the person, this is truly patient-centered. Patients might also meet other patients, exchange experiences also, and that might also be beneficial for people with MSA and also for their caregivers. You can organize research within these day clinics because this is very structured and systematic. So you can organize research, and you can also try to identify some quality measures. The challenge for these day clinics is that their capacity is rather limited. They may not be able to focus themselves on multiple system atrophy alone, but they might also involve people with Parkinson's disease. So it's the limited capacity of these day clinics is truly a problem. Again, some of that time that is invested in organizing the care for the person with MSA is probably not reimbursed and might put some stress on the team. There's there's not a lot of research, but there is some research on how this influences the care, and this is a Dutch study that has been conducted within the Parkinson network. The Parkinson network is a system, a network that organizes multidisciplinary care. And what is shown in the table is how likely people that have been treated within the Parkinson network multidisciplinary care are likely or not likely to see one of the healthcare workers. It's obvious that the neurologist and the movement disorder specialist is often seen, but for example, the Parkinson nurse, you're more likely to encounter when you're cared within that multidisciplinary team than if you're cared for outside of such a team, let's say routine medical care. The same goes for the physiotherapist, even though the difference here is smaller. And as you can see from the numbers, it's much more likely that you will see an ergotherapist or an occupational therapist when you're treated within the network than outside of the network. Again, depending on the healthcare needs at that particular time and for that particular patient. When you organize multidisciplinary care, it's customary to identify, and especially if that's organized within a daycare clinic, to organize a number of measures or to use a number of measures that can identify whether it's done in a highly qualitative way. And I'm not going to spend a lot of time on this, but you can, for example, identify process indicators. How often have you seen the dietitian? How often have you seen the psychologist? And you might say these are just numbers, but there's also something behind those numbers. And that's the organization of the multidisciplinary care, the satisfaction of people. These are more outcome indicators. For example, is the diagnosis made sooner? Is there more patient and family satisfaction involved? Can we prevent hospitalizations, for example, as a complication? Other types of outcome indicators that are, let's say, more likely to be important and significant for a patient and for family. And it should not only involve quantitative analysis of the quality, but also a qualitative, a more narrative type of analysis. Tell me what you think was better as opposed to the previous way the care was organized. Can you tell us 3 things that you find acceptable, or that you find, let's say, signs of good quality? And can you also identify 3 issues that might be improved? Again, don't want to spend a lot of time on this, but patient and caregiver education go along. It should be something that we learn from our patients, and I hope that by working together, that the patients, families learn from us. It's important that somebody finds that sense of autonomy, so that you know what a particular symptom is, that you know how it occurs, and that you know what you can do about it, be it a medical treatment, a treatment that is non-pharmacologic, not by medication, but by something that you do or something that you wear, and that gives you more sense of control over your own condition. And if people are involved in that sense in their care, I hope that they are more felt supported, and also retrieve a little bit of their autonomy, and retrieve also a bit of hope. There are a number of consortia that we should remember and that organize and facilitate scientific research in multiple system atrophy. Any reference center, like for example in the European Network of Rare Neurological Diseases, should have also a connection to one of these networks in order to do scientific research. So some of the take-home messages from my contribution to this family conference, that is one of the challenges of multiple system atrophy and that we all face, patients and families alike, is that it's a rare disease. And so healthcare workers tend to be less exposed, they have less experience, and it's our obligation, our common obligation, in order to share these experiences and make that the neurologist, the Parkinson nurse, and the other healthcare workers develop that experience by sharing information and trying to think out of the box. We as physicians, and I'm sure this goes for other healthcare workers, we tend to listen to the things we recognize, that we can give some meaning within the knowledge that we already have. But we need to think out of the box, we need to listen out of the box and identify new healthcare needs, for example. Some of these healthcare needs are predictable because we know a lot by all the registries that exist and the experience that people have exchanged. Example is a database on healthcare needs and signs and symptoms that exists, in which the MSA coalition has certainly been involved. Some of the healthcare needs are unpredictable and should be taken care of immediately. The care should be patient and caregiver centered and shouldn't be the other way around. The multidisciplinary team and the reference center I've given a definition of, and I've explained the role of the Parkinson nurse and the movement disorder specialist, and especially how to recognize them. And in these reference centers that's the place where patients meet the healthcare team. Again, patient and healthcare worker should learn from each other, and these experiences should be shared and should be made available to the whole network, let's say. How multidisciplinary consultation should be organized, whether they should be organized in day clinics or other types of network, whether it should be official or more unofficial, whether it should be countrywide or not, depends a little bit on the situation that you're confronted with within a particular country, and not in the least the type of insurance that you can get. And quality improvement should be, let's say, one point of attention because it's often driven by the experience that patients and family have in obtaining the care. And with this, this is the end of my presentation. I'll be happy to answer any questions during the Q&A that comes later on. Thank you.